Okay, so inhaled nitric oxide, we know it's a gas, and once we breathe it in, it causes our pulmonary vessels to dilate. But why does that happen? Who is it indicated for? How much should you use? What are the dangers? That's what we'll go through in this lecture. It's very expensive to have nitric oxide on a patient, so hospitals are desperately looking for other ways of dilating the pulmonary vessels. I think Memorial Healthcare spends millions every year just to have nitric oxide available in case it's used. To have that service call, hey, we need help, or have the cylinders on board, and so they spend so much money. Coming up with alternatives, of course, is what there's a lot of research being done on. So to start the lecture, I want to tell you something. So three compounds, NO, N2O, and NO2. So NO is nitric oxide. This is a pulmonary vasodilator. So nitric oxide, pulmonary vasodilator. The second one is nitrous oxide. So NitrOUS, nitrous oxide. Nitrous oxide is an analgesic. So it's a gas that's typically used in the dental office before a procedure to cause a euphoric feeling. You don't care that your tooth is being ripped out of your jaw, it's fine. So that's nitrous oxide. And then the third one is nitrogen dioxide. So two oxygen atoms connected to nitrogen. So nitrogen dioxide, and that is a toxic gas. We do not want to breathe in nitric oxide. It causes inflammatory inflammation in the tissues in the lungs, so damaging to the lungs. Not a good thing to be inhaling nitrogen dioxide. So this is showing the Inomax, and this is the company that makes a delivery device for nitric oxide. So they call their machine the Inomax. Why does nitric oxide work so well? It says when inhaled, nitric oxide goes to open alveoli and dilates the blood vessels around the open alveoli. So if you have a collapsed alveolus, there's no nitric oxide going to the collapsed alveolus, only going to the alveolus that's getting air. So if you dilate the blood vessels around the good alveoli, you're going to have good ventilation and good perfusion occurring around that alveolus. So good ventilation, good perfusion, the oxygenation in the patient will improve. So does that make sense when it says VQ mismatch improves? So where you have good ventilation, you'll have good perfusion. That's improving the mismatch. So the mechanism of action for nitrous oxide, nitric oxide, it increases something in the cells called cyclic GMP. And when there's an increase in cyclic GMP, it causes pulmonary vessels to dilate. So that's where the research is going on. It's looking for ways of increasing cyclic GMP, Once we get that increased in the cell, then the muscle relaxes. Nitric oxide has a rapid onset of action. Within 30 minutes, there's going to be a response to that pulmonary vasodilator. And you know there's a response, again, because oxygenation improves. So if your sats are 88%, you put the nitric oxide in line and it's running, and then within 30 minutes, your oxygen saturation is now 95%. That's because you've got better perfusion going to the good alveoli. It does have a short half-life, so as soon as it's administered, it's pretty much gone. The nice thing about delivering nitric oxide via the lungs is you don't have systemic absorption. So you don't have a lot of the nitric oxide getting into the blood and then causing vasodilation throughout the entire body and therefore low blood pressure. Because just to give something intravenously to dilate the pulmonary vessels, it affects everything in the body. So then now you've got to deal with low blood pressure and trying to get those pulmonary vessels dilated. So that's the beauty of just delivering to the respiratory system. The metabolites of nitric oxide are cleared by the kidneys, so you don't get a buildup of anything toxic in the blood. All right, and then I want to show you the mechanism of action at inomax.com.
Inomax nitric oxide gas for inhalation is indicated to improve oxygenation and reduce the need for extracorporeal membrane oxygenation in term and near term greater than 34 weeks gestation neonates with hypoxic respiratory failure associated with clinical or echocardiographic evidence of pulmonary hypertension in conjunction with ventilatory support and other appropriate agents. Inomax is contraindicated in treatment of neonates dependent on right to left shunting.
Why does it say that? Why would you not give Inomax to somebody who is dependent on right to left shunting of blood?
Is it not going to make a difference?
No.
If it's right to left, that means that they need the blood to go to the aorta. So if you're it's going to be lower pressure resistance if you get the Inomax, right?
Yeah.
So
Yeah, so giving the Inomax, you would decrease the pulmonary vascular resistance. You'd get more blood flowing to the lungs, but what if you don't want that? What if you want the blood to go into the aorta and not flow to the lungs? Now you would have that happening. So giving nitric oxide, it lowers resistance in the pulmonary vessels. And then if you lower the resistance, you're going to have more blood flowing to the lungs and less blood flowing across the ductus into the aorta.
Blood. Please see full important safety information at the end of this video and visit inomax.com for full prescribing information. Optimal oxygenation of the pulmonary vasculature is vital. In order for this to occur, ventilation and perfusion matching, or VQ matching, is required. Healthy neonates can achieve the ideal VQ ratio of approximately 1. But in those with hypoxic respiratory failure associated with pulmonary hypertension, VQ mismatching negatively impacts oxygenation. One cause of VQ mismatching could be intrapulmonary shunting, which can cause the VQ ratio to be less than 1. Another cause of VQ mismatching could be the creation of dead space, where there is adequate ventilation but poor perfusion. This could cause the VQ ratio to be greater than 1. Inhaled nitric oxide, or INO, is an inhaled pulmonary vasodilator that can improve VQ matching when there is pulmonary hypertension. How does INO address VQ mismatch? Inhaled nitric oxide is delivered with ventilatory support, and with ventilatory support has a preferential affinity for well-recruited alveoli. Once in the alveoli, inhaled nitric oxide diffuses into the smooth muscle of the arteriole. There, inhaled nitric oxide activates transduction pathways, relaxing the smooth muscle cells, which results in selective and local vasodilation of the pulmonary vasculature, and in turn improves VQ matching. INOMAX, nitric oxide gas for inhalation, also known as inhaled nitric oxide, is an FDA-approved drug that selectively dilates the pulmonary vasculature. INOMAX is rapidly inactivated by hemoglobin. Because it is inhaled, INOMAX minimizes systemic vasodilation. Nitrate, the predominant metabolite of nitric oxide, is rapidly cleared by the kidneys. INOMAX can help restore VQ matching in your vulnerable patients. When you have a neonate patient who suffers from VQ mismatching due to hypoxic respiratory failure associated with pulmonary hypertension, think INOMAX, because every moment counts.
I love the
Important
drama.
Safety information. INOMAX is contraindicated in the treatment of neonates dependent on right to left shunting of blood. Abrupt discontinuation of INOMAX may lead to increasing pulmonary artery pressure and worsening oxygenation. Methemoglobinemia and NO2 levels are dose dependent. Nitric oxide donor compounds may have an additive effect with INOMAX on the risk of developing methemoglobinemia. Nitrogen dioxide may cause airway inflammation and damage to lung tissues. In patients with pre-existing left ventricular dysfunction, INOMAX may increase pulmonary capillary wedge pressure, leading to pulmonary edema. Monitor for PaO2, inspired NO2, and methemoglobin during INOMAX administration. INOMAX must be administered using a calibrated FDA-cleared nitric oxide delivery system.
Yeah, they make sure that you can't just get a cylinder of nitric oxide and on your own, put it on the baby and bleed it in. So they have everything where you can't use nitric oxide unless you're using their system. Yeah. Question?
Is it also like contraindicated then if there's some kind of like kidney disorder in the baby? Since they can't, it might not be functioning right to filter out the nitrate.
Yeah, possibly. All right, some notes to write down. Is it safe for healthcare workers if some nitric oxide gets into the atmosphere? So yes, according to the INOMAX company, nitric oxide diffuses so rapidly. There's no way that it accumulates in a small area. So even if there's no reason for this, but let's just say the cylinder was turned on and it's bleeding into the atmosphere and you're standing in that room, you're not going to have dilated pulmonary vessels because it just diffuses so quickly. However, one of our graduates is here for the respiratory care week party and she's pregnant. And she said she's not allowed in CPICU because of nitric oxide being used there. So that made no sense to me. I don't understand.
I had a therapist that I was with and she was showing me how to use the nitric oxide machine and we were turning it on and you could smell like the nitrate. And she's like, oh, don't sit there, don't be around it too long because it can give you a migraine. And that's something else she had to do.
Interesting.
I would, I'd like to see years of extent briefly because we've been connected.
So you used it also?
That judge actually told me how to review it.
Ah. Oh, interesting. Yes, I don't know why there's this care where you can't be in a unit if they're using it and you're pregnant. So I don't understand. But is it safe for healthcare workers? I have yes, the gas quickly dissipates in the atmosphere. For using nitric oxide, it's approved by FDA for PPHN. And that's it. So as far as FDA approving its use, only for PPHN of the neonate, so persistent pulmonary hypertension of the neonate. Is it approved by the FDA for use on adults? No.
Really?
Is it used for pediatrics? That's not approved by the FDA. So that might run into problems with insurance reimbursing if the patient is placed on it.
Wait, so it's only indicated for the use in neonates and on adults, and I've seen it in adults.
Yeah. A lot, yes.
And then
Oh.
But is it FDA approved? No, so it's considered off-label, I guess, you know that more than I do.
Off-label. Okay,
Yeah, off-label use.
so is Respiratory FDA approved for?
Good question, I don't know. I'll have to find that out for next week.
And then going back to how I asked you like a month or two ago, because I saw the nitric used on preemies and you're saying it's.
Yeah.
Full term.
Yeah, so I don't understand. I mean, if they put it on and it made a difference in O2 saturation, it's got to be dilating some pulmonary vessels. But the thought with premature babies, well, here it just says what, greater than 34 weeks. But preemies don't have a lot of smooth muscle yet around their pulmonary vessels, so they don't respond to nitric oxide. So I guess that would be considered off-label if they're using it on a preemie. Yeah, I'm in peds also. Yeah. With heart surgery or no?
It was a hard, yeah.
Oh, okay. So off-label for adults and peds, use it on greater than 34 weeks gestation. And then I have PPHN from hypoxia. Or, oh, we know that already. Oh, the cause of PPHN is a hypoxic event around the time of birth. That causes the pulmonary vessels to constrict, and instead of relaxing like they do after birth, they stay constricted. So that's PPHN. Right, side effects with delivering nitric oxide is met hemoglobin forms. And we know that if we have met hemoglobin, that hemoglobin cannot carry oxygen. So it kind of takes away the ability for that hemoglobin to carry oxygen. So that's why we don't like met hemoglobin. It has to be monitored. So drawing a blood gas, you want to look at your met hemoglobin levels. Here it says after the first 8 hours, and then every 24 hours, you need to check. If the met hemoglobin level is greater than 5%, it says to discontinue nitric oxide, because now we're interfering with oxygen carrying capacity of the hemoglobin. Nitrogen dioxide may form if the flow of gas containing nitric oxide is stagnant. So the oxygen in the atmosphere can combine with nitric oxide and make it nitrogen dioxide. So any stagnant air not moving, you get nitrogen dioxide. And that includes in the circuit. So when you're setting up a circuit with nitric oxide, and let's say you have it running into the circuit and you put the circuit on standby and maybe you're bagging the infant. You can't just reconnect the circuit. So you have to run some flow through the circuit, get rid of that stagnant air because it's got nitrogen dioxide in it, and then you attach it to the baby. Bleed the system, yeah. Always bleed the system, always bleed the circuit before attaching to the neonate. And then in my notes, I just have that it takes within 30 seconds, you get nitrogen dioxide forming. So just a 30-second disconnect or standby, you've got nitrogen dioxide in your circuit. And then, of course, it says nitrogen dioxide is dangerous if inhaled, leads to airway inflammation, damage to lung tissue. So you're going to be monitoring this all the time with the INOMAX. If you see that the nitrogen dioxide is more than 1.5 parts per million, you know how tiny that is? That's too much. So on the monitor with INOMAX, you look at your interface and you'll see that you're monitoring FiO2. You'll monitor SpO2, but that's separate from the machine. That's not with the machine. So that's a separate pulse oximetry reading. But on the front, you'll see your FiO2. You'll see the amount of nitrogen dioxide. And then, of course, the dose of nitric oxide that you're delivering. So that always shows up. Is it okay to turn off nitric oxide delivery? And it says no. It will lead to increasing pulmonary artery pressures and worsening oxygenation. So is that called a rebound effect? Is there a name for that? Like I heard with migraine headaches, if you're taking NSAIDs all the time and then you stop taking NSAIDs, you get a migraine. It's like a rebound effect. That's true?
It is, it happened to me.
Oh, really?
If it wears off, the headache comes back angrier.
Wow, okay. So same thing here, the pulmonary vessels get more angry and they constrict even more. So when you're turning off nitric oxide, obviously you have to wean down the dosage before you can turn it off. Once you get down to 1 part per million, it's good to turn it off. Oh. I need to look at my notes as I'm talking to you guys. So I have the sampling port. There's a sampling port near the patient that pulls a little bit of the flow of gas. The flow of gas in the circuit, samples it, and that's how you get your readings. So let me write down. So I wrote down there is a sampling port that you place in line with the ventilator circuit. You place it near the Y on the inspiratory side. Gas flow is pulled from the circuit about 230 mLs every minute. And then it goes inside the INOMAX, and the INOMAX will tell you what FiO2 you're delivering. It'll tell you if there's any nitrogen dioxide in the gas, and it'll also tell you how many parts per million of nitric oxide is in the inhaled gas. Okay, and then how much nitric oxide? Where was that one? Okay. So you can use up to 20 parts per million. It says start with 5 parts per million. So when you turn it on, you start with 5 parts per million. And double it every 15 minutes. Right. So when starting nitric oxide, you start off with 5 parts per million, and then you see if the 5 parts per million makes the O2 saturation come up into normal range. If it does, that's all you need is 5 parts per million. But if you're not seeing a response at 5 parts per million, maybe more would help. So then you increase it to double, so 10 parts per million. If O2 saturation doesn't improve, you can double that and go to 20 parts per million. All right, so it says if there's no improvement in oxygenation, there is no need to go to a higher concentration. But usually as I'm lecturing to you guys, somebody says, oh no, I saw 40 parts per million. So just to let you know that this is what is FDA approved. The studies that they did showed that you don't get any more benefit after 20 parts per million. So if 20 parts per million isn't doing the job, you're just wasting money by going up to 40 parts per million. So that's according to the INAMAX educator. Okay, and then I also have the INAMAX is billed according to time and not to dosage. I wonder if it's more expensive now because these notes are a few years old. I have $147 an hour for nitric oxide to be running. So what does that come to if the baby is on it for a week? It's a huge amount of money. So having the wow, $25,000 a week. Can you imagine? And then turn off the cylinder when it is not being used, because it's the hours that the cylinder is on. So even if you have you're not using it, but you just have the cylinder turned on and ready, there's a charge that occurs with that. So I remember, gosh, when did I work Joe DiMaggio? 2005. Were you guys born then?
Yeah. We were born.
And somebody had left a cylinder on, and the charge to the hospital from that, it was huge. And then there was a big blow up. Everybody was upset. So yeah, make sure that if it's not being used, the cylinder has to be turned off, because there's a little counter in the cylinder and it just keeps counting the hours if it's left on. So it's got to be turned off when you're not using it. So how fast can nitric oxide be weaned? It says first, cut the dose in half each time every 4 hours. So it doesn't say every 4 hours on here. Uh-oh. Tiffany. You guys ready to take a break? We're almost done, I know. So you cut the dose in half each time. When you're down to 5 parts per million, now you go by 1. So 5 to 4, you wait 2 hours. 4 to 3, you wait 2 hours until you're down to 1 part per million. And then you can shut it off. Okay, and then the question I have in my notes is. So, oh, that's supposed to be capital O. How do you know if the decrease in nitric oxide is being tolerated?
If your O2 stats like this full.
Excellent, yes. So you're checking your SpO2s as you're doing this. And it says if FiO2 has to be increased by 20%, then the patient is not tolerating the wean. So I guess it's okay to go up to 20% and say that, yes, they're tolerating it. So if FiO2 has to be increased by 20%, the baby is not tolerating the wean. What does the INOMAX DSIR look like? So here it says inhaled nitric oxide delivery system with infrared technology. So INO, inhaled nitric oxide, nothing about the max, I guess. DS is delivery system. IR is infrared technology. So the infrared technology is the cylinder sends off this beam, and the INOMAX unit has to recognize that beam to say, okay, you're using our cylinder and it's okay. But if you get your own nitric oxide and put it in there, it's not going to have that special infrared beam, and then INOMAX won't work. Yes. Yeah, because there aren't any other systems out there. And then looking at the unit itself. So you're going to have 2 cylinders on the back. So there's 2 connectors here, and it's kind of tiny in the picture. Doesn't show up very well. So here you're monitoring your oxygen level, the toxic gas, the nitrogen dioxide, the units of nitric oxide you're delivering. The little tiny unit that sits in between that and then the main unit is where you would attach an ambu bag. So if you have to remove the ventilator circuit and bag the patient, you want to still be delivering nitric oxide. So you would connect your ambu bag here, not to the blender on the wall, but right here. And then of course you can't just start bagging the baby, because remember there's stagnant air inside that bag. Yeah, you have to squeeze it a few times, get some fresh air in there before you can connect it to the infant's endo tube and start bagging. So those 2 connections, one of them I already told you about, where there's sampling of the gas from the circuit. that goes back into this unit, and that's what tells you what you're monitoring. So one of them is the sampling port. And the other one, narrow. Is the injector module. So the injector module, it's got to be coming up, right? Yes, next slide. So here's a picture at the bottom. It shows a rough drawing of the ventilator. So we know in the ventilator, we've got air coming out of the ventilator, going to the heated humidifier, and then from the heated humidifier going to the patient, and then of course the exhale back into the ventilator. So that's the ventilator circuit. It says sample T, so we know that we're taking a sample of the air to analyze it. And then the other part is the injector module, and you're going to put that on the dry side of the humidifier, which means you're putting it between the ventilator and the humidifier. So that's where you put the injector module. The injector module is the intelligence of this unit because it quickly can analyze how much air is flowing to the patient and figure out how much nitric oxide to put into that flow of air to keep the parts per million exactly what you want it to be. Like, there's no room for error. You're delivering exactly the parts per million that you want to. So that's, somebody came up with this, and that's probably why they charge millions, because they figured out how to carefully monitor the injection of the nitric oxide. So that's the injector module. And then what's also interesting about the setup, in the cylinder, it's got 800 parts per million of nitric oxide. The rest of it is nitrogen. So you can't have any oxygen in the cylinder. Because if you do, the oxygen is going to combine with the nitric oxide and form nitrogen dioxide, which is toxic. So you can't have any oxygen in the cylinder. So with that being stated, as you're taking some nitric oxide and nitrogen out of the cylinder, it's going to dilute the FiO2. So you can never get 100% FiO2 delivery when you're injecting nitric oxide into the circuit. So let me put that down. Okay, so I wrote, because the injector module adds nitric oxide with nitrogen to the circuit, it dilutes the amount of oxygen in the inhaled air. That is why the analyzed FiO2 will always be a little lower than the selected FiO2 on the ventilator. Okay, and then I have some other notes. Should I add this or does this already make sense? So the injector module measures the flow in the circuit and determines how much nitric oxide to inject to give the prescribed dosage. Is that a bunch of words of just saying the injector module does its thing?
No, but it's good because that's how you ask your questions.
So write it down.
Yeah. You get a test, you're not gonna say. just like that.
You weren't done with that?
I
Ah,
wasn't done with it.
ah.
Is it on the recording?
We have to do it. We just not doing it.
It does.
Oh dear.
So what's on there? Don't worry.
It's okay.
Did anybody finish writing it? And you can just, can you say the whole thing? After you swallow.
It's after because. After, what was the what?
Then, you know, what comes after that is why to analyze the FiO2.
Will always be lower than the selected FiO2 on the ventilator.
Should I rewrite it?
No, you don't.
Everybody got it?
Let's get to the next- What's the next part?
All right, you got that part? Okay, I can write some down, some notes down here. So Inamax can also be set up with nasal cannula, with vapotherm, with the oscillator, with a transport vent, and of course with a regular ventilator. Oh. Didn't I say nasal cannula? So the system can be set up with obviously a conventional ventilator, a transport ventilator, an oscillator, a nasal cannula, and vapotherm. You got that? Okay. Okay, and then one more thing. And then this is redundant, so I don't even know if I need to write it. The circuit needs to be purged prior to connecting the patient. This gets rid of a buildup of nitrogen dioxide, which is poisonous. You already know that, or write it again?
Write it again. Please. Right. You look this thing like the transport, it's still that whole big dolly and everything, right? You got the transport van and the.
Oh, in order to get the Inamax to be moving along during transport, does it run on battery? Is that what you're
There's
asking?
that, but it's also kind of cumbersome. It's another piece of, you know.
Yeah, so let's figure out in our minds why you would be transporting a baby on nitric oxide. Like, what if they want to take the baby to surgery?
Yeah, there was one in Broward who was on nitric and we had to transfer her to Jody.
Oh, wow.
Do they make a smaller unit for transport, or there was?
Oh, good question. Yeah, it seems like they could have a smaller cylinder and then that monitoring screen could be smaller. So maybe there is a transport unit. I don't know. Brent?
That's good baby transport to surgery and back. And like on the transport, they have incubator that they use to transport. They have a nitric tank in the back, like oxygen is on one side and then the nitric tank is on the next. But it doesn't look like it's set up with like the ion.
Ah, so maybe there is a transport setup that's a lot smaller.
But it's just a tank and it's hooked up already. You just gotta crank it up.
Okay,
It doesn't have this full ion set up.
it probably does, but it looks different maybe.
Maybe, because
When you say crank it up, like what was?
it looks like it just has a knob and you just turn it. And then it has several monitors, like on one side, the monitors, like a EKG, then the monitors blowing feed. You can set those settings and everything.
I don't think Animax would be separate.
I'm gonna check it out when I go back
Okay.
the next day. But
Yeah,
I did
maybe
see
you
the-
can
I
ask if
did
you
see
can
the
take a
tank.
picture of
Okay. But I did see the nitrous tank, but I think
nitric.
nitric tank is.
Yeah, so, yeah, I would like a picture. That would be great.
When I used to transfer NICU patients, they had their own stretcher, collapsible stretcher, like that comes out of the rescue. And they had the whole, it was everything you could possibly need to transport a baby was attached to that thing. And
Wow.
when I got on scene, I would leave my stretcher there and take theirs and put that in the trunk.
And then you had to go back and get yours.
Incubator, it had oxygen, it had every single thing. It looked like something out of outer space.
Wow.
I didn't really have much NICU experience at that time, so like you'd always go with two nurses from NICU that would travel with us. And then we'd be responsible for everything.
Oh, I see.
It's a huge setup. To kind of work out of the building, like it's one thing to go down to CT or surgery or something like that, but if you have to leave the building, you gotta break everything.
I see. Oh, very cool. So the circuit needs to be purged prior to connecting the patient. This gets rid of buildup of nitrogen dioxide, which is poisonous.
You don't reuse certain. It sounds like you reuse the certain, like you put a brand new circuit.
The injector module, I don't know how it's disinfected between patients, but that doesn't get thrown away. The injector module does get used between patients. Tijin? Oh, really? Oh, awesome. I didn't know that. Okay. Backup bamboo bag, you turn on your flow. Set your parts per million, but then make sure you squeeze the bag several times to get rid of any stagnant air that would have nitrogen dioxide in it. And that's what the little box looks like on the Inamax. During delivery of nitric oxide, what does the Inamax monitor? We've already talked about this, so nitric oxide, nitrogen dioxide, and FiO2. That's it. All right, so I have a worksheet to give you, but I have to go downstairs and make a copy of it. And then the answers are already posted in D2L. I'll try to answer them without looking in D2L. Let me stop the recording.